All right, it is 1:05. We're going to get started with, we are going to get started with who's in the room. I am Fanya Burford-Berry. I'm the director of the Westside Heroin Opioid Task Force. And if you are new to the task force meeting, if you can raise your hand and come off mute, and I will call on you. I'm flying solo today. My partners are out doing various things. I'll call on you. Tell us your name, the organization you're with, your role in that organization, and what brings you to the meeting. So your name, the organization, your role, and what brings you to the meeting. So who is new to the meeting? Raise your hand. We don't have anybody new to the meeting? I know Nathan and them are new to the meeting from Westside Rising.
Hi, Belinda McKinley, A Safe Haven Foundation. I'm new to this meeting on behalf of A Safe Haven and Margarita Gonzalez. Thank you guys for having me. Good to be here.
Welcome, Belinda.
Hey, Fanya, did you want me to introduce myself?
Yes, Dr. Orr, introduce your team to everybody.
Okay. Hey, Fanya. Hello, everybody on Opioid Task Force. I'm Dr. Orr. I'm the director for Westside Rising, and we're focused in Austin, North Lawndale, Humboldt Park, and Garfield Park. And today I'm here with our youth interns from Chicago Lights, and I think Dylan, Chanel, and Nathan are on with us today, and they can introduce themselves. Go ahead.
My name is Nathan Sarpong. I'm along with Westside Rising as a youth ambassador. And I'm just here to get some new information to improve my life and get a better understanding of from advice from the older generation.
Excuse me, Dr. Orr, I didn't hear that last part you said. I heard Dylan and then you cut out.
Introduce yourself, Dylan. That's all I said.
Okay. I'm Dylan Holmes. I'm with Chicago Lights. I'm in this meeting to just gain some more information. And just to be clear, this is I think I read opioid. This is an opioid meeting, correct?
That is correct, Dylan.
Okay.
Anybody else here, Dr. Orr, from your team?
Yes, I know Chanel is here. She may.
Yeah, I'm here.
Okay, go ahead and introduce yourself, sweetheart.
Hi, everybody. I'm Chanel. I'm with Westside Rising as a youth ambassador. I'm pretty much just here to learn more about opioids and how to, better help us as youth.
All right. Thank you, Chanel. All right. And we have Ebenezer up in the corner.
Hi, everyone. I'm Ebenezer Hammond. I am the program director here at Phoenix Recovery Support Services. I work closely with Fanya Hernandez. I used to come to this meeting a few years back when I was the program manager. I left the organization and I've now come back as the director. So I'm here to rejoin the festivities.
All right, Ebenezer. Welcome back. All right. Anybody else new to the meeting? All right, Allie.
Oh, not sure if we'll introduce ourselves later. One of the presenters from the city, but Allie Lichterman, Mayor's Office of Community Safety.
All right, welcome, Allie.
Same, Mariana Osoria, First Deputy of Human Services. Can share more later, but I'm with the Mayor's Office and we'll be presenting today with Allie.
All right, very good. Anybody else new to the meeting? Okay, we had to switch around a little bit. We're gonna have Tim Devitt present first from the housing, and then we'll have Sherri Keyes, and then we'll have Taylor present. All right, so Tim, tell us any kind of updates regarding housing.
Yeah, we had hello everyone. We had a meeting in early June was our last meeting, and at that meeting, the three priorities for this work group are let's just back up, are addressing the needs of people who have emergency shelter needs, the addressing the needs of people that have more transitional housing needs and then permanent supported housing needs. And our conversation was more focused on emergency housing needs, and it kind of with more attention to medical needs as well, and identifying that we need more places where people can go for medical needs. So trying to build up some resources for street outreach groups and other groups that are working with people who are unhoused, and where they can help people get to. So we reached out. We have one group that's tentative to attend our next group. We're hoping the Boulevard offered. We had a correspondence, and they offered to come to a future meeting. So we're trying to get that set for sure for the next meeting, which is August 5th at 11 a.m. So an invite will go out real soon, probably later today for that. But that's a big one. We're also anyone that has recommendations or groups that we might be able to invite for that discussion, please enter it in the chat, because we'd love to include them as well. So shelters where medical care is provided, or shelters that have specific services that address medical needs is what we'll be focusing on. But that's our current area that we're addressing for the next meeting. Yeah, so if there's any again, August 5th, we'll have that going out real soon today. Thank you.
All right, thank you, Tim, for your report. Tim is going to be monitoring the chat for questions. If you got questions regarding anything, he's going to be interrupting and saying, hey, here's a question. So our next person up to do a report is Sherri Keyes regarding warm handoffs and family guidance.
Hi, everyone. My name is Sherri Keyes. I'm with Family Guidance Center. I'm the Senior Program Manager over Community Outreach. And for those of you who don't know, we have a medication van that goes out 4 days a week with a partner, and 2 days a week, Westside Task Force, we partner with them. Basically, what we do is we go out in the community with them, and we canvass the area for individuals who would like to get medicated on methadone. And once they get medicated on the van, they are now part of the program, and they're given a bus card to go to a clinic of their choice. So far for this year, we have dosed, and that's what we call medicated. We've dosed 18 individuals through the Westside Task Force. It's been a little bit slow, but what I will say, June was a really good month. We actually had 4 that we dosed with Westside Task Force. So far for July, we've had 2, and we've had 2 that are still successfully coming to the clinic weekly. Both of those individuals, they do receive take homes, so they don't come to the clinic every day. But yeah, we still have 2 that are successfully in the program. We've also had a couple people that have gone to detox, from us being out there partnering with Westside Task Force as well. So far, we're still out there fighting a good fight and getting the van out, getting that information out, and working together. Thank you, guys.
All right, thank you, Sherri. Does anybody have any questions for Sherri? All right, thank you for the good work you're doing. I know everybody's excited because they're waiting for Taylor and their presentation regarding what's in the drug supply. Taylor, are you ready?
I am pulling it up now as we speak.
All right.
Sorry about that.
Oh, take your time.
It's been a share my screen. All right. Can everyone see this okay?
Yes. Mm-hmm.
Awesome. So this is the Chicago Recovery Alliance. I apologize for the typo here. This will actually be over April through present. Although most of the GCMS data for confirmatory that we have falls between April through parts of May, or parts of June. I apologize. We are waiting for the rest of those results. We've sent out about, we have sent out about 83. We've had 49 returned. But this first slide will kind of go over just some of the emerging and re-emerging substances that we have experienced in this kind of period. We did admittedly have a period of stability within the supply. For a while, we were beginning to see heroin and 6-monoacetylmorphine represented within our supply to a higher degree. Last year, it fell around 30%, 25 to 35, give or take. This year, it's since January bumped up to about 65% for both heroin and 6-monoacetylmorphine. But once May came, we started seeing some drastic changes in our trends. The one that I'm sure we're all very familiar with now is the medetomidine. This caused an overdose spike over Mother's Day weekend, and we have continued to see it represented in some of the samples that have been brought to us. In addition, the nitazines have unfortunately returned from January to April. We only had one nitazine crop up, which was metodesniatazine, or yes, metodesniatazine. My apologies, there's so many meadows now. This one is on par with morphine, so not really problematic if experienced by those who are, used to using fentanyl. But once May came again, we saw N-pyridino metaniatazine, metaniatazine itself. The N-pyralidinos are stronger forms of them in them of itself. They're also known as metaniatapine. Similarly, we saw etaniatazine, but etaniatapine. We also saw protoniatapine or N-pyralidino protoniatazine. Metaniatazine is on par with fentanyl if you look at the MOR, the morphine equivalencies. But the N-pyralidino addition can spike that to, about 1,500 versus just 1,000. And the protoniatazine is speculated to be double potency of fentanyl. We have seen these come and go in the past year, but in the recent data, we have seen samples that have contained, unfortunately, all of these. In addition, xylazine has remained, and it has cropped up in some samples also containing medetomidine. Now, the benzos, on the other hand, have lessened to some extent, but we still have seen bromazolam, as well as desal. That one I'm not going to be able to say, and alprazolam. Alprazolam's unique because it's Xanax, and we rarely, if ever, this is probably the first time that I have seen in our data alprazolam represented with dope or heroin samples in Chicagoland area. It's just not typical, so I don't know if that was cross-contamination or something else, but it did represent in some of the samples containing medetomidine. Now, this next slide, this is essentially our test strip data. As we can see on the left-hand side, we have the category as well as substance sold as. This is all data representing from April until now. The dope samples, we've had 59 of them, heroin 25. We also had 4 samples represented as fentanyl and heroin. We had 1 morphine sample and 0 samples represented as either fentanyl or just tranq alone. Tranq being fentanyl or heroin or another opioid or opiate with xylazine and now arguably medetomidine. The reason why those are 0 is this is based off of what the substance was sold as and represented to us. So the results can differ as we go through the analysis. But we can see the fentanyl test strip results here. 84 or 86.4% of all the dope samples were positive using the fentanyl test strips. Likewise, 13.6 were positive using the benzo strips. And then down below, we can see the XYL, which is xylazine, the OPI, which is opiate, and then the NIT, which is nitazines. All of these have been represented as well. Xylazine, 11.9% for dope. Opiates, 32.2%, which makes sense. We do still have heroin and 6-monoacetylmorphine present. And then nitazines, 15.3%. What this represents is when in our lab, when we use a test strip, you know, positive, negative result, or if we didn't run it, or it just, we didn't have enough material to run it without risking not having anything to send for confirmatory. We also have those mentioned here as the xylazine negatives, as well as the non-available or not availables. In total, across the board for all opioids, fentanyl test strips were 86.5% positive. The benzos were 13.5% positive. The xylazine were 12.4% positive. The opiates were 24.7% positive, and the nitazines were 11.2% positive. This next slide, same deal, but now we're looking at the Brooker match. The Brooker is the brand name of the FTIR that we use in-house, the Alpha 2. What this kind of goes to show is we utilize the FTIR, we utilize the test strips, and we also have confirmatory data. The test strips, you know, you're honing in on specifically one thing, but the fentanyl test strip will test for all of the fentanyls and its analogs, whereas the FTIR can actually differentiate between which one we're seeing. However, the FTIR has a limitation threshold of 5%, meaning that if in a bag, a dope bag, you know, there's 6 to 12 different substances, some, you know, active, some not. If any of those fall below 5%, it becomes very difficult for us to pick it up using the FTIR. But we're able to use all of these technologies in conjunction to get a better understanding. But here we can see that only 34.8% were a match to what it was sold as. Now, this could either be it was inappropriately identified or inappropriately sold as something else, or it could mean that, you know, what was containing within fell below that threshold. But we can see that with the dope samples, 44.1% of those we were able to see fentanyl and other substances therein. What that can tell us, if using the previous slide of the test strips of the 86.4%, roughly half of our samples for dope have fallen below that threshold in terms of fentanyl's presence, whereas the other half have fallen above. Likewise, we've added in the xylazine and medetomidine. Medetomidine in total has, at least on the FTIR, been represented 9% of the time. That may be skewed. I do want to double check on, yes. Now down below is the GCMS results. These are samples that we send out for confirmatory analysis. We can see that we've sent out 43 of the 59 dope samples. 21 of those matched the description of dope. Therefore, 48.8% do match what the sample was sold as. But in total, only 39.3% of the opioid samples matched their definition. Likewise, the GCMS fent, the GCMS xylazine, GCMS medetomidine, and GCMS nitazines. This more so just shows their actual representation in each one of these samples here. So we can see in the dope samples, fentanyl was represented 41.9%, xylazine 14%, medetomidine 14%, and the nitazines 11.6%. This final slide I would like to show is just the raw GCMS data, or the confirmatory data that we've received from our partners at CFSRE. Some of these samples you can see have a lot of components. Here's the one with the decile gitazepam. We have seen ketamine pop up in some of the samples, which admittedly is to be expected. We are seeing ketamine kind of reach a multitude of communities. It also is shown to have some assisting effects to pain relief from fentanyl. So it's not as odd of a thing to see that cropping up given the trends in overall acceptance of ketamine use. We can also see some of these have medetomidine. For some of these, medetomidine was the primary active substance. Specifically with this sample here, it had fentanyl and trace. In order for them to even pick up the fentanyl, they had to run QTOF, which is an even more precise analysis that they're able to do. It's a different machine entirely. We will also have quantification for these available, but CFSRE runs that once a month, so we are waiting on some of those results. And then up here you can see the alprazolam also in trace, which leads me to believe that that may be cross-contamination. It is interesting to note that we had two different styles of dope samples representative of the medetomidines presence. One which looks kind of like last year's stereotypical dope sample. It has a slew of substances from fentanyl to parafluorofentanyl, xylazine, ketamine, diphenhydramine, or as we know as Benadryl or Dormans. Also alprazolam again, which is odd, quinine, metronidazine, and the N-pyridino metronidazine, and medetomidine was present for this. But the other samples that we were seeing were heroin samples. Fentanyl again was in trace, but medetomidine made for the larger part of it. It ranged from 6.3 all the way up to 12. Likewise, this sample down here was predominantly Dormans and medetomidine. It did have some 6-monoacetylmorphine, more 6-monoacetylmorphine than heroin, which is interesting. And yeah, that's pretty much a kind of a snapshot of what we've been experiencing since May. Most of these are from May, and part of these are from June. And I should provide a caveat. I'm only focusing on the opioid samples here with these results. We've sent out confirmatory for stimulants and other substances, but none of those have returned any kind of out of the ordinary results or trends. So I just wanted to mainly focus on this supply. But if anybody has any questions or comments, please feel free to put in the chat or to raise your hand, and I'd be happy to answer those for you. Yes, Tanya.
So much for this information, Taylor. I know we had been discussing whether we should also look at supplying rebreathers or plastic rebreathers in utilizing evidence-based to say we also need to encourage folks to do rescue breathing.
Yes.
You know, we had a little bit of difficulties with legal and discussion of how CPR is then implied with rescue breathing, but with the increase of not only the xylazine, medetomidine, and some others, some nitazines, are we looking for potential avenues to also provide rebreathers or plastic rebreathers as part of our outreach? And what do you guys suggest?
I would advise that. I've admittedly been frustrated how COVID created this situation where people pulled back from rescue breaths. We know that rescue breaths are as important, if not more important, than naloxone administration itself. It keeps the oxygen flowing to the brain. You know, I know there are now even debates on whether it would be feasible to provide those portable oxygen cans that can sometimes be used, you know, for athletic purposes or high altitude purposes, for someone coming out of, you know, an overdose experience that can also provide some relief. And I do believe Remedy Alliance is doing a test pilot with those at the moment. But I'm really, really happy you bring this up, because that is something that absolutely needs to be hammered in, as rescue breaths are absolutely important, especially, as you noted, the presence of xylazine as well as medetomidine. You know, these substances can keep people in a state of shallow breathing. It, you know, can enable people to still have overdose-like symptoms and experience even past administration of naloxone. So I do think it is very important to reintegrate that into outreach, and also how we, you know, present to our communities the importance of rescue breaths.
Thanks. We've been looking for literature reviews or any discussions that's out there on the rebreathers, and we're not seeing too much either. So if there may be some other agencies, I know I've spoken to John about this with CRA, but if there may be also some other agencies that want to look at how we could incorporate that in our outreach, it might be nice to have an additional kind of subcommittee working on that, so that we might be able to at least do a feasibility study, something that might be publishable and get disseminated, because there's a dearth of evidence on that now, although we know anecdotally and almost scientifically that that's certainly needed.
Yes. I wish I knew of, I can, later this day and this week, I can do some research to see if I can pull together some fact sheets or some articles about that, but that is something that I think I need to do a deep dive for.
Thank you, Taylor, and thank you, Dr. Sorrell, for your comments. I even talked to COIP about the sobering tent and having oxygen on the sobering tent, as well as I think maybe the mobile units might think about having oxygen as well. So
I know that at On Point in New York City, the OPC, they heavily rely on oxygen more so than naloxone. The amount of naloxone they provide is pretty low. I've gotten to shadow there maybe 3 times now, and it is really remarkable to see the space and see how they operate with that, as well as the drug checking that's embedded in that space, which, you know, hopefully someday we will be able to replicate that.
all right. Anybody have any more questions for Taylor? All right, thank you, Taylor, for your presentation. As always, it is always full of facts and sobering information for our work. So thank you once again. All right, we're going to move on to Dr. Hua and the Chicago Department of Public Health, and they're going to tell you about our canvassing program this summer.
Thanks, Fanya. I'm gonna keep it short just because this is the same information that I'm sure you're probably somewhat sick of hearing me talk about. But you know, just have a couple of slides. I don't know. Are you seeing my slides, or have it popped up to a different screen?
Oh, we don't see any slides yet. So did I make you a call?
Okay, all right, let me.
Oh, so there we go. Okay.
Okay, all right, what is going on? Okay. All right, now you're seeing my slides?
No.
No? Okay.
Oh, there we go.
Okay, perfect. So yes, as many of you have heard, we are kicking off Operation Summer Overdose Safety SOS on Saturday. So this weekend, the goal is to reach these priority blocks, which have seen at least one overdose in 2023 in the 5 West Side neighborhoods. that see over 30% of overdoses citywide. So this is going to continue for, probably the good part of the next 12 months, but over the summer is when we're hoping to have the densest level of activity, starting out in the neighborhood of Austin, which is the West Side Heroin Opioid Task Force's home base, as well as the region where we see the highest number of overdoses in private residences. So the plan this Saturday is we are going to have, so we have a save the date flyer on the left and the leave behind flyer on the right, in case you're wondering why there are two flyers that look very similar. But the save the day flyer, so this is the one that I think hopefully someone on my team can drop this in the chat. If not, I can, but please disseminate in your networks. We are going to be there at 10:30 for the community to come help build kits. We anticipate that Mayor Brandon Johnson will also be there at 10:30 to give us remarks and participate in kit building, as he is also a resident of Austin. And then the first knock is going to be at 11. We anticipate media presence. We really are looking forward to seeing many of you there. And I'm actually requesting for some of the organizations, particularly who've been doing this work with us for such a long time. If you can let us know in the chat, when you can be there and how many folks could potentially be there before the end of this meeting, just so we can get a head count and figure out how many folks will be there from the start of festivities. And we will have supplies to build at least 1,000 leave behind bags. So hopefully there's plenty of things to do for everybody who's involved. And yeah, I sort of leave it to the street outreach team and West Side Heroin Opioid Task Force, who are experts in doing this. If Fanya, you and I know you're flying solo today, but if you have anything to add, the flyer on the right is just what we would leave behind. Folks that don't open the door or aren't home, and there are information there to get in touch with both CDPH and Lou Sias. So yeah, Fanya, if you have any additional comments, I don't really have anything else to say.
All right, thank you, Dr. Hua. I would like to say, because we've already, Dora was able to work with a group of young people from West Garfield Park, and they made 300 bags. The bags are pretty light, and they're really nice totes that you could take to the grocery store. So if you have, and this is what I'm got to hear clearly, if you have a brick and mortar on the West Side that does treatment and recovery and mental health services, a brick and mortar in our neighborhoods, right? In the neighborhoods that we serve, Austin, East and West Garfield Park, North Lawndale, and Humboldt Park. And you have services directly in those areas, because we really want to be hyper local. Please come bring your brochures to our office. We will stuff the bags with your brochures, and we've taken one task out the way for Saturday. So if you have brochures, 1,000 of them in your office, and as well as even if you're not even your community organization, we will stuff those bags, because what we want to do when we go door to door is the bag is the key. We're going to say to the neighbors, right? Because they're going to be curious about why we're carrying these bags. We're going to say in this bag is some life-saving, quality of life materials. And then we'll pull things out to show them, like show and tell, and say, these are the agencies in our area that work with people with substance use disorder. These are agencies that if you're thinking about need of housing, or if you are in need of mental health care, here is an agency in this bag that can help you, and engage in about a 10-minute conversations with the residents on the West Side of Chicago regarding substance use disorder and opioid use disorder, right? As well as mental health and all things dealing with quality of life. And so please, if your agencies have that, I'm gonna put our address in the chat. Drop those 1,000 brochures off so we can fill up these bags, these goodie bags, so that our residents know about your services. A lot of people, believe it or not, as much as we say, we advertise, we promote and advertise. The truth be told, until it's happening in your family or people tell you over and over again, then you realize that there's, oh, this is a problem, this is an issue, and these are the resources in my community to help out. Does anybody have any questions? We're excited about this campaign. Also, too, we're going to be door knocking, like the task force and the street outreach team will be door knocking for, a couple weeks. Once we get a rhythm, we would love to invite agencies who have community engagement people to come out and door knock with us. So be watching for when it's time for other agencies to join us and see how it works, then you are welcome to come on to door knock with us as well. So, but that will be in a couple of weeks or a few weeks from now. All right, I see Dr. Orr, is that you have a hand or question?
Nope, I hear you. I hear you. I already know.
Yeah. Anybody else? Anybody else? Questions, comments, thoughts, ideas? All right, then this is moving really quickly. So our next presenters are, and thank you, Dr. Hua, for presenting. We're so excited about this project. I'm like busting at the seams because I do think, as I told everybody before, because I'm a pastor, we are participating in a miracle right now. And we're going to see changes on the west side of Chicago when it comes to opioid and heroin usage. So, all right. And
Can I just chime in for one last thing? So
yeah.
I know it might be difficult to speak on behalf of your organization, but if you intend to come out on Saturday, again, 10:30 to 1, you don't have to make it for the whole time, but Mayor Johnson is expected to be there around 10:30 and we'll have cameras rolling for the whole time to some extent. Can I see a show of hands of how many of you might be able to be there? Feel free to just pop it up or do the sort of hand raise function. Okay, great. Thank you so much.
All right. Okay, very good. Thank you. Thank you very much. Thank you. All right, next group, Amy, are you going to be coming or you have a question? Tim's going to be there. Amy's going to be there. All right, bring your materials about vets. Amy, is really important for us to have brochures and information about vets, the veterans.
Yes.
Yes. Have a question, Amy?
No, I'm trying to figure out how to put my handbag down.
Okay, all right. All right. I understand. Okay, our next group will be talking about Treatment Not Trauma, the initiative. And so we have Mariana and Allie from the mayor's office, as I think they're both from the mayor's office. All right.
Thank you all so much for having us here. We'll do quick introductions and then we'll go through the presentation. We both unfortunately have a very tight schedule. Allie's got to jump at 1:55. I've got to jump at 2. So if we're not able to answer all questions today, we're happy to come back, and thank you so much for including us. Again, my name is Mariana Osoria. I'm the First Deputy of Human Services in the Education, Youth, and Human Services team in the Mayor's office. Under Deputy Mayor Jen Johnson. And I'm going to pass it over to Allie to just introduce herself.
Hi, Allie Lichterman, she, her. I'm a senior policy advisor in the Mayor's Office of Community Safety under Deputy Mayor of Community Safety, Gary and Gatewood. And I largely focus on alternate crisis response. So I work with CARE, our alternate response teams, and led the alternate response behavioral health crisis response portion of the mental health system expansion work.
Great, thank you, Allie. I am going to share my screen and hopefully it will work. Do you all see my screen? Okay, so very shortly, I'm not going to be able to see people's heads shaking, etc. But and hopefully you all still see my screen. So what we want to talk about with you today, and thank you again for the invitation, is the People's Plan for Mental Health System Expansion. And what we came up with most recently in May, and then also how we're going to move this work forward. You all probably have seen this already, the mayor's vision of how we deliver a better, stronger, safer future for the city of Chicago. Obviously, our vision, or the mayor's vision, is to have a better, stronger, safer future, one where youth and our communities have access to tools, resources that they need to be able to live successfully and thrive. The mission is to do this in partnership with all Chicagoans and be informed by data. We want to correct those systems and practices that have created those inequities that we have seen for far too long. We want to aim to repair those past harms that have contributed to purposeful disinvestment and exclusion. And I know that you all are seeing that every single day in the work that you do. And we want to usher in that new era of inclusive, effective governance that creates a better, stronger, and safer Chicago. One of the ways that we want to do this in the administration, the mayor himself has mental health as one of his core areas of policy that he wants to ensure that, you know, we're making some shifts. This graph that you see here, this map, demonstrates the unmet mental health treatment need in city-funded mental health services locations. So you can see here that there are a number of community areas that are not fully covered with our care programs. So you see these with the lines are the care locations, and then other beyond the clinic walls, and then physical actual locations are blue. That includes partners as well as CDPH direct clinics, but it certainly does not cover all of the city. And we know from, you know, partners and from our own analysis that there is still a dearth of services, in particular mental health services, to meet the needs of everyday Chicagoans in the best way that they need them. So as a result of that, and just to, I don't think my colleague Noreen has been able to join yet today. I don't think, no, yeah,
Nope,
but I
just
do want to share that she was also one of the co-authors of this report and helped lead the overall objective, which was established by the City Council ordinance to have a mental health system expansion working group. And her name is Noreen Hashim Jawani, and she is in the mayor's office as well on the policy team. And those concrete recommendations and framework were supposed to resolve or begin to resolve for set the foundation for expanding mental health clinical services, so that direct service, instating a non-police response for behavioral and mental health crises, and increasing community awareness of available mental health resources. Folks that were included in this work, in the working groups and contributed, were representatives from Fire, from the Chicago Department of Public Health, 2FM, so Fleet and Facilities Management, the Department of Human Resources, the Office of Budget and the Mayor's Office, and the Office of Emergency Management and Communications. So that was really a cross-team, citywide, full force of government response to be able to develop the framework that was come up with. In addition to that, the ordinance required that we consult with at least 10 individual community folks, and we overall were able to reach and connect with over 400 community members through direct activities that the city of Chicago did, as well as in partnership with advocates, and in particular the Collaboration for Community Wellness. I'm going to give you a second to, if you haven't already, screenshot or look at that QR code so that you can have access to the mental health system expansion report. And again, we encourage you all to share this across your networks. It's not a secret. We want it to be broad, and we know that we're going to continue to need to engage with folks as we move forward. here is just, I'm not going to read all these, so don't worry, but this is just an example of the different folks and experts that we had communications with. So we had from direct clinicians, folks on the alternate response side, community members, other partners, such as labor, that really connected and worked with us and helped to frame the final result, which was a report. We have identified in terms of all of those three areas that there are overarching recommendations that are going to impact all three of those goals. One, of course, is integrating program connections between clinical service expansion and behavioral health crisis. So ensuring that our care teams, and as we expand that, they not only are being able to respond to crises, but they also are connecting with clinical services that are delivered by the Chicago Department of Public Health and able to make real connections, both on the clinical side for participants or patients or clients or Chicagoans, but also for our clinicians, right? Identifying and thinking about what do we need to have in our clinical settings that respond to both the needs of our residents, but also our clinical team members. Clearly, this costs dollars, right? So we need to ensure that we create a comprehensive funding analysis and budget exploration strategy. That's going to look at a number of things, like what are the dollars that we have now? What do we know dollars that are ending? What opportunities are there at the city, the state, the federal level to be able to invest and really think about in a comprehensive manner what our vision is and how that budget will align with that vision. And third, we are designing and implementing a robust plan to build a community care core. That really is the staff, the folks that are delivering the services. And then creating a capital plan. So what are the buildings? What are they going to look like? And identifying those metrics and evaluation plans. So the first goal is to expand mental health clinical services. That was one of the concrete things. I'm going to briefly go through this one, but we identified 4 areas or 4 ways to increase mental health services. One is to layer that mental health service into existing CDPH clinics that don't offer that, co-locate mental health services with other city services such as Chicago Public Libraries, Chicago Public Schools, city colleges, etc. Open brand new mental health clinics. That's another strategy that we've identified. And then finally, reopening previously closed city-run mental health centers. And so as you can see in 2024, we've actually been able to do 3 out of those 4 opportunities, right? We're reopening the Roseland Mental Health Clinic, which was shuttered. We're layering in Lower West in a CDPH clinic that is already has services there, but not mental health services. And then just this last month, we were able to expand into Legler Regional Library to co-locate mental health services there. And so you'll see that we have this in phases. There are a number of recommendations, which you would see in the report, that are under each of these phases. Again, that first one is developing that comprehensive vision. Then the next phase is how do we lay out that groundwork to be able to respond to the needs of community in the way that they want them. And then 3, fully launch what we call a certified community behavioral health clinic and implementation plan. Within those 3 phases, you'll see around clinical expansion, different recommendations, such as one that is identifying and analyzing the mental health ecosystem, because we know we can't do this alone. We haven't ever done it alone, but we want to be intentional and have a full picture of who we're serving, where, and going back to that mapping. So we'll continue to do that work. I'll pass this over quickly to Allie.
Hi, Allie, again, still. I apologize in advance that I'm about to go through this pretty quickly. I am just dipped out of a student re-engagement retreat, but I'm happy to put my information in the chat if you'd like to follow up. And my colleague Noreen, who we talked about earlier, is here and can do a lot of the follow-up questions. So I want to start by talking about the overall vision for behavioral health crisis response, a lot of which the groundwork was laid by our incredible care teams. So we think we need to have a whole range of crisis response for behavioral health, from pre-response through post-response. So we should have a no wrong door approach. You should be able to call 988-211, 311, 911 and get connected to the right resource for you in that minute. We should then have a continuum of behavioral health care responses to get you the right resource at the right time and consistent follow-up afterwards to make sure that you have that consistent care and that we are connecting you with resources, expanding resources so that we do our best to prevent another crisis. We know that if the underlying issue is someone needs housing and we don't help fix that, they're just going to keep getting more acute and likely be in crisis again. Next slide, please. So phases also align with critical services because we know that these systems need to interact. We both need to respond in crisis, but also have places to take people that aren't just the emergency department and that are consistently available. Similar to clinical services, we have some really exciting 2024 wins, which is that we are doubling our number of care alternate response teams already in the budget, thanks to the mayor. And we are in the process of shifting CPD and CFD off the care vehicles, making all of our on-van staff under CDPH. So that is a health-driven model of behavioral health crisis response. We actually are in the process of hiring our EMTs and additional crisis clinicians through CDPH right now. So that's all happening in phase one. Oop, if you can go back, and then we'll move into expanding our reach and really planning alongside our partners at the health department, emergency management, public safety administration, and human resources, fleet and facilities management, all the people involved in making something operational, do all the things we need to make this a permanent part of our emergency response network, and then finally moving towards expanding our hours. Right now, care teams are not 24/7. We will slowly build towards that and citywide coverage, knowing that we want this to be eventually as accessible as fire, police, EMS are right now. And with that, I will throw it maybe to my colleague, to either to Mariana or Noreen to walk us through the community engagement piece.
Noreen, do you want to go ahead or do you want me
Yeah,
to?
sure. Hey, everyone. Apologies for joining a little bit later here, but really happy to be with all of you and so excited to share this plan with all of you. The third goal within, the treatment, not trauma, and the mental health system expansion working group is to increase community awareness of available mental health resources. And so what that means, and you'll see this in the report, are a few different strategies around how do we ensure that we are creating an integrated behavioral health continuum of care that includes both prevention, crisis response, and treatment focused alternate destinations across Chicago's neighborhoods. Like Mariana mentioned earlier, this does require us to continue to partner with 2FM. It requires us to continuing to partner with CDPH and some of our other departments so that we can make sure that we are building towards sustainable public infrastructures of care. And so we're really thinking about not just like what is necessary in this year, but what is necessary in the next few years as we're building out this continuum. So just a few different recommendations. I won't read everything on the slide. I know it's a lot of text here, but just something to draw your attention to. Again, we are making sure that we are developing and implementing a multilingual public awareness campaign so that residents are informed of what are the current available mental health resources, what is coming up, and also be able to continue to partner with us. Again, I think Mariana mentioned this, Allie mentioned this as well, but we are very eager to partner with all of you and other community members as we're building out this community engagement portfolio, because we do want to make sure that in addition to town halls like this one, we are continuing to do workshops, we're continuing to do listening sessions, even co-developing some of these information campaigns so that we can make sure that it really is reaching the community members that we're hoping to serve here. The third is, we've heard this from several different sources. We do want to make sure that we're improving our appointment booking process. I know that different folks need different ways to book appointments. And so really considering some of that as we're kind of looking forward. So not just making sure that you are aware of like what are the opportunities available in terms of the resources, but also how can we streamline and better serve the needs of our community. Again, I won't read the rest of this because some of this was covered earlier in the slides, but here to answer any questions that you might have on some of the other recommendations within the report. I will wrap up here with, I know that we have our QR code that will kind of bring up again, but if you do have questions, comments, feedback, we are here for that. There is our email address there if you do want to reach out to us with how to get involved further, or if you have any suggestions for us even from this deck. Happy to hear that. And then of course, our website there, which has our report, it has a lot of future meetings coming up, a lot of information there. And if you see anything missing, know that everything is in draft form, at least in terms of the website. Even the report, these recommendations are a starting point is how we're looking at it. And we're going to continue building these out further and further. And so really appreciate all of your partnership and all of your feedback as we're kind of, doing this for the first time together.
Thank you, Noreen. I appreciate that. Again, I believe that you all have this deck, and if not, we'll make sure that you get it. But you also can, follow those links, and we can put them in the chat as well. I don't know, Noreen, how much time you have, but I do have to jump for another meeting, but I'm very interested in hearing questions and being able to have dialogue and communication on your response. And as I mentioned, if you all invite us again, we're happy to come to have further conversation about this report, which, really is just a starting point and very exciting starting point for sure. But, want to continue to keep the dialogue open.
Thank you, Mariana. Anybody have any questions? Noreen, do we have you for a minute?
Yeah, I can be on for a few more minutes here. So
All
happy to-
right.
yeah.
All right, thank you, Mariana. You can jump off. There we go. Anybody have any questions?
Yes, I do.
Yes.
Fanya. Hi, good afternoon. This is Dr. Jangi from Bobby, right? I don't have question, I have comments. I know all of this sound wonderful, but I constantly wonder, instead of reinventing the wheel, creating new or refurbish mental health services, there are agencies like Bobby Wright who have been in the communities for over 50 years, providing behavioral health services without any help from the city. And I think looking at this holistically for the city, if they are looking for sustainability, it would be better for them to invest in our agencies, especially in the West Side, as we are doing the task force here for behavioral health, not just a crisis, but reinvesting in us. And as everybody knows, funding drives services. And to me, it sounds like we are reinventing the wheels. Historically, the city of Chicago was supported the communities with 26 mental health services in the past. And gradually it went down to 4 or 5 right now. And then here we are again doing the same thing. We are going to expand this. So I'm just concerned, and it's just my comment is like, I heard this before, and not being pessimistic, but we are here. And as we have been here for 50 years, and I know other agencies have been here longer than we have, we just need support. We just need not just doing the community engagement and doing the public media, we need financial support, because by not having enough staff, we cannot do the job. So I don't know how the city is going to address that. So sorry, I didn't want to be long. I have more to say, but I'm just going to stop there.
Yeah, well, first, just want to thank all the work that you've been doing for all of these decades. It really doesn't go unnoticed. And I think that was exactly part of some of the data that we were looking at. So part of the process as we were building out some of our maps and some of our decisions around where clinics will be was in consideration of where are some of the existing organizations and how are we, supporting gaps versus recreating the wheel. So definitely hear you on that. And I also hear the realism of how do we continue to partner and invest with organizations that are doing the good work already? And so that is actually part of the ordinance that founded our working group. It was to ensure that we were in consultation with organizations like you all. And then that's something that we plan to continue to do. So in terms of how do we invest as a city, that is still an open question that I think we need to still come to a conclusion on in terms of how much will we invest further. And that is still going to be ongoing work. So even if the formal working group process is going to be sunsetting at the end of this month by ordinance, our plan is to continue to do some of this work in partnership with you so that we can understand how we can support through funding, resources, anything else, some of the work that you're already putting in. So I really appreciate all of the work that you're doing here.
Thank you, Dr. Ahmed, for that comment. And anybody else have any questions?
Just to comment, Fanya, there are a number of links and attachments that have been posted in the chats related to going back to Operation SOS and the expansion of the mental health system documents as well.
Thank you, Tim. I don't want substance use to be overlooked when you guys are working to create new mental health organizations and buildings and having a conversation about having an overdose prevention site may be connected when you guys start to plan and develop these sites, right? And reopen up these clinics and preparing the workforce to understand what a overdose prevention site is and what that looks like and how we can all work together so that it's not like, so mental health has a lot of it covers a lot, right? But part of mental health is substance use. And so just making sure it's not left on the back burner when it comes to this conversation.
You always could count on us, Fanya.
I know. I got you. We got a plan going on with this new women's treatment center. Yeah. So, yeah. You guys had conversations regarding that with the plan? Is that in the plan?
Sorry, Fanya, I think I heard part of your question and part of your feedback there. It is actually being something that we are considering through our CDPH. So that is something that they are helping us think through a little bit better in terms of how do we ensure that we're not just stretching resources in a way that's going to leave everyone thin in terms of like what they need to provide quality care, but also what are ways that we can be strategic, because we do know that there is an overlap of some of these needs that are necessary. And so that is something being considered. I know that it's in Mariana's slide that she had shared where she had mentioned there's going to be a layering of services. So where there are like identified vulnerable populations, if there are existing clinics or if there is a component of substance use, like how do we ensure that we are layering in mental health versus again, like creating a brand new, next door, if you will, clinic. And so I think that's something that we are definitely thinking about is like, how do we make sure that these are streamlined processes? We know through having worked with a lot of community members now that they do want to be able to come in and receive the full resource package, right? Not just like have to go from appointment to appointment for different sorts of cares. And so that is definitely something that we are considering. I would still love to like continue to hear from you and learn from you on how we can do it better, because I think that can't get lost in the mix either.
Thank you, Noreen. You're always welcome to come back. Anybody else have any questions, comments? All right. Sort of going back to like your AmeriCorps idea, we have now Liz Thomas, who is a cousin of mine, right? Because of Thomas, I'm like to a lot of Thomasons. Yes. So she's going to talk about Recovery Corps.
Thank you, Fanya. Appreciate you. I'm going to go ahead and just dive right in. All right. Can everyone see my screen? Is that working all right? Okay, cool. I'm Liz Thompson. I use she, her pronouns. I work with an organization called AMPACT, which is a national nonprofit that specializes in evidence-based AmeriCorps programs. So I'm the executive director of Illinois programs, which includes Recovery Corps. So I'm going to be talking with y'all today about Recovery Corps. Some of y'all may remember me from my affiliation with Malcolm X College, and I began working with AMPACT as of February this year. So still pretty new in this role, but really excited to be here. So yeah, Recovery Corps, our big goal here is to build capacity to support recovery in our state. that includes Chicago too. And I'm local to Chicago. I've been living here for 16 years now. So, and I also am a resident of the West Side. So as far as Recovery Corps goes, we are an AmeriCorps program, and we train folks to serve as recovery navigators or recovery project coordinators. We are located in Illinois, as well as Minnesota and Virginia. And so, as I mentioned earlier, our big focus is to expand capacity for recovery services, as well as to strengthen the recovery workforce in our state. So this isn't new to any of y'all, especially since the pandemic. We have seen a huge increase of not only folks who are reporting using substances, but also overdose deaths. We also know that Illinois only has a fraction of the workforce needed to address these substance use and mental health challenges for our state. So workforce development is a huge focus for us. We train up AmeriCorps members to essentially become peer recovery specialists, and we train project coordinators to work with our partner sites to build their capacity for recovery services to make recovery possible for more people. So the recovery navigators, we like to refer to them as kind of like peer recovery specialists in training, right? They all have at least one year of lived experience with recovery, and they train to support clients one-on-one with goal setting, resource navigation, accessing benefits or services, housing, employment, and other wraparound services that would support their recovery. And then the recovery project coordinators have more of an administrative role, and they work directly with their partnered sites to work on a service plan and to build capacity. They focus on things like program development, community outreach, data collection, communication, that sort of thing. Our project coordinators do not have a requirement to have lived experience in recovery, but the large majority of the folks that we've recruited actually still do. And so as I mentioned, we are currently in 3 states. Minnesota was the first state to implement Recovery Corps, and Illinois, we are coming into our 4th year of service now. We've been around since 2021. And I know that we have a few of our partners on this call. We do partner with a few Chicago-based organizations, including Healthcare Alternative Systems, A Safe Haven, Family Guidance, Above and Beyond. So we're super excited to, continue to work with y'all. So our goal this year is to train and mobilize 40 members in Illinois. We have nearly recruited already that number of individuals. But if folks want to partner with us, we accept applications on a rolling basis and kind of assign members as we have the capacity to. And I'll talk a little bit more about that in just a moment. So as I said, most of our Recovery Corps members, especially all of our recovery navigators, have at least 1 year of lived experience in recovery from substance use disorder. And we work with a wide range of Recovery Corps members in terms of gender, age range, folks, the experience that they're bringing to the table. Some do have experience in the recovery workforce, some are brand new to it. So it's really exciting to get that diversity among our Recovery Corps members. So as far as their commitment to their year of service with Recovery Corps, they can choose to serve part-time or full-time. Their start dates are July, September, and January, and they can serve up to 11 months. So when we think about partnerships, we focus on organizations that have a demonstrated need for building capacity for recovery services. So this would include public entities. It could, include the health department. It could include nonprofit organizations or educational institutions as well. Most of our partners fall into the category of treatment center, recovery home, or recovery-focused community-based organization. So here's what AMPACT provides. We give the members a stipend, which is equivalent to around $15 an hour, including health insurance, child care assistance as well. And for every year that they serve with AmeriCorps, they receive up to $7,395 stipend for tuition or to go towards their student loans. At a certain age, I believe if the AmeriCorps member is like 50 or 55, they can also choose to transfer that award to a family member as well, which is pretty cool. So in addition to those benefits, which AMPACT pays for, we also provide those members with all of the training and onboarding needed to prepare them for their role as a recovery navigator or a project coordinator. They also get coaching support. So not only would they have a supervisor at their assigned site, but they're also assigned to a program coach with Recovery Corps to provide them with support along the way. And as a partnering organization, you would get people power to help build your capacity to provide recovery services. So of course, that includes a dedicated member. Some folks have more than one member at their site for a period of up to 11 months. You would also get technical assistance from the AMPACT team to implement this program at your site. And then also when you think about the long term, access to a talent pool for potential employees. A huge portion of our partnering sites are actually able to hire on their AmeriCorps member as a full-time employee after their year or years of service. And then the commitment from the partnering organization side would be a supervisor to support that member, of course, the physical workspace and tools to be able to do their role, assistance with, even identifying candidates who might be a good fit for a service here at their organization. And then also Recovery Corps needs assessment that can support the development of a customized service plan to increase their capacity for recovery services. So by working together, we can increase capacity for recovery support in the community. We can generate improved outcomes. We also have access to a really cool evaluation team that can help us to look at the big picture and to show the impact of this work. And overall, healthier communities and more support in the community. So we're still working on collecting and aggregating our outcomes for this past service year. But the service year prior to that, for 22-23, we served over 2,000 clients with 84 recovery navigators. The clients who were served by these recovery navigators on average increased their recovery capital scores by nearly 3.5 points. And then of those members, 34 project coordinators were estimated to have increased the number of people served at 75% of their sites, so the large majority. And then demographics among our members, nearly half identify as female, 31% is non-white, and 62% are between the ages of 25 and 44. but we're seeing our member pool diversify year over year, which is really cool as we expand. So as far as next steps, so like, why am I here talking to y'all today? I want y'all to be aware of this resource. If you need that expanded capacity and people power at your organization to support recovery with substance use disorder, this might be a really great resource for you. Also, if you work with, if your organization serves participants who have at least a year of experience with recovery and are interested in joining the peer recovery workforce, this might be a good opportunity for them as well. What I can do is send out additional information to Fanya, not just about what you can do if you're interested in being a partner, but information that you can share with the clients at your organization who might be interested in having a year of service with Recovery Corps. And then just some frequently asked questions before we break. I think it's we're coming up close to time. So if you're interested in partnering, it's important to know the site supervisors who are committing to that supervision of the Recovery Corps member. We're looking at about 6 to 9 hours per member per month of that supervision, you know, their primary point of contact, and supporting them with their training. As far as the recovery project coordinators, the kinds of projects that they've worked on, we have folks who have helped organizations create a brand new, you know, peer recovery program or initiative or an outreach service. We've had folks focus on community engagement or a communications or marketing plan for their recovery programs. Research, data collection, helping to fine tune your data collection tools or generate reports and analyze the data that you're collecting. Managing and mobilizing volunteers, focusing on harm reduction services, workforce development, or internal process improvement. So, you know, the sky's the limit almost for these projects, but, you know, the ultimate goal really is to strengthen and build capacity for your recovery services. And then the training that the members receive, they get an introduction to substance use disorder and recovery. They get a DEI training. They get trained in peer support and motivational interviewing, stakeholder and project management. And then this is really, really key here, but the recovery navigators also attend a training where we partner with Heartland Community College, and they provide them with the required number of education hours that they would need to be eligible to apply for the Certified Peer Recovery Specialist credentialing exam. So we also support them with their application and exam fees if that's the route that they want to take when they wrap up that training and wrap up their service hours with us. So we're also increasing the number of certified peer recovery specialists in the recovery landscape in the state. All right, so Fanya can send out these slides to everyone, which have links that are embedded to that direct you to the position descriptions and, you know, the guide to partnering, our marketing toolkit, the application link, if you're interested in becoming a site, and all that. So you are also free to reach out to me directly with any questions, but I'm really excited to be back here with the task force and looking forward to, you know, continuing to see y'all month to month. So thanks for the time, Fanya. Good to see everybody.
Thank you, Liz. Anybody have any questions for Liz? I do not see. Tim, is there anything in the chat?
Not specific to this so much. There was a comment about, following your comment in the last discussion about mental health expansion, about just a comment by about some substance use treatment facilities that serve dual diagnosis. There are some, but they may have limited mental health staff. The assessments tend to be more based on disclosure than clinical interview with the physician. There was just a comment as well.
All right. All right, Liz, thank you. We're going to be partnering with you because I got too many projects. I need help. All right. So anybody well, once again, any comments for Liz? Thank you. I love your program. I think it's amazing. Member announcements. Does anybody have any member announcements? Raise your hand. Is there any of special events that you want to invite people to? Anything like that? All right, group. Hey, very good. For us, we have International Overdose Awareness Day, August 30th from 11 to 1. We want to see all our partner agencies out there. It's going to be a great time. And also, too, the National Rally for Recovery is happening September 21st. I know everybody, we're going to have fun in these next couple of months with getting together, telling people about the services and opportunities that our agencies have and our organizations have, creating a healthier Chicago, right? Creating people to have healthier usage, right? As well as if they want to have abstinence. So I think we are all done. I see Liz is excited. I'm excited to have Liz back in the fold. Yes. Once again, any questions, comments, concerns before we adjourn? Anything? Oh, Isabelita, what were you saying?
Hi, Miss Fanya. How are you? How's the family doing? How's everyone doing here today? I started a chat and stuff because on overdose awareness is in August.
Yeah.
And Healthcare Alternative System is planning to facilitate a group with a specialty group on overdose prevention. What I am wondering if anybody knows a mom that has experienced the death of a child due to overdose, and if I can have connections or can we connect, so then that way she can be our special guest. And so if anybody knows, please, I will write my information down with my email, have them contact me, so then that way to see their availability and invite them over to be our special guest at this this special group.
Yeah, thank you.
Thank you.
Yes. All right, I see nobody else has their hands up. You guys, it is time to go. You have a great afternoon. All right, get out and enjoy the sun and see you next week.